Thank you again.
Mhm.
Thank you again, Camilla. And it's always great to see new members of the physiotherapy working group, and of course, like everyone, and with in this networking event. My talk is entitled "Beyond Symptoms: How Illness Narratives Can Help Shape Physiotherapy Approaches in Huntington's Disease." My name is Paul Carreon, and I am based in Liverpool, United Kingdom. Essentially, my talk is about stories. And when we approach stories, I invite all of you to have an open mind. And within this open mind, a little bit of reflection as well of how we can use stories in our physiotherapy approaches. And always remember the stories of the patients and families that we look after, essentially for people with Huntington's disease. The outline of my talk is divided into three sections. On the first part, I'll provide a little bit of introduction. I will dwell on the illness narrative theory conceptualized by Arthur Frank. Then we will lead to revisiting our EHDN physiotherapy guidelines, and I will provide a case study for a patient with Huntington's disease. And lastly, in the third part, we'll have a room for discussion, implications for clinical practice, and we will draw it for a close. So this is around 30 to 45 minutes with room for questions. It's, I'm going to start my own story first. So to make it short, I was qualified in 2003, and from very early on, I had this beginning to dedicate my career to specializing in neurological rehabilitation. But not until 2009 when I first met my first Huntington's disease patient, and it sparked a great interest in complexities of Huntington's disease care. I reached out to the European Huntington's Disease Network by then and attended and I met Lori Quinn and Monica Booth, but not until in 2011, well, I officially joined the EHDN Physiotherapy Working Group and been active ever since. And from there on, I had my master's research and completed it and presented it in my first EHDN conference in 2018. Follow on 5 years after that, I earned a PhD in health, focusing on the illness narratives for people with Huntington's disease. And in current time, I continue to practice in Huntington's disease care with specialty more on Huntington's disease research, where I run the Enroll HD clinic together with um, our principal investigator. I am an associate PI and also like with upcoming clinical trials in Huntington's disease based in Liverpool. And these are a little bit of snapshots of the highlights of the physiotherapy working group where we all met together, we talk, and also like we discuss and share the common journey that we have, and also the challenges and the goal and of making a measurable difference for people with Huntington's disease. And on the right side is here, I would say that's one of the happiest moments of my life. Where finally I got my PhD at the time where it seems to be impossible because I was doing it at the height of the pandemic. But that's my journey. That's a little bit about myself and my journey so far. Now, that is my journey. Reflecting back on the journey or stories of our patients, it is not as linear or straightforward as I would put it. From discovering the faulty gene to their family, their implications to it into their offsprings, their jobs, their future, and it's not as there's not seem to be like a straightforward approach on how people navigate through the disease illness. More so when there is like the development and of the disease symptoms and into the disease progression. In the changing narratives of people with Huntington's disease, this shift from a focus from a primarily motor symptoms, early described by George Huntington in 1872, of what we called a medical curiosity curiosity, which in terms of a hereditary Korea, which it's moved to a more comprehensive understanding of what we know as the devastating cognitive and behavioral impacts of the disease, that it's not just a motor symptom. More so as well, people and their stories have been the center of it, despite the stigma, the history, and the hopes of the recent hopes, most especially of what we heard in the news recently about the Unicure's breakthrough therapy of being successfully treated for the first time with 75 disease progression. So, but along this changing narratives is there's always a patient and the family stories alongside these changing narratives of people of our understanding of Huntington's disease. So, what is the inspiration of this talk? It's the countless stories that I've encountered and heard from patients and families, and more so as of health professionals, as well as every time we gather together in the physiotherapy working group, it's the stories of the physiotherapy colleague experiences in Huntington's disease care. I think Dr. Noit Inbar talk about ethical dilemmas earlier this year about how this relevance to this talk and the illness narratives. And Mutmu always mentioned that how can, and also in his interest in his past conversations about how can we promote better empathy for people with Huntington's disease. This inspiration in my talk as well is my own research interest and the findings of my PhD study, where I look at resignation in the absence of cure, where I focus on the disease progression and the illness of experience of people with Huntington's disease. So why does this matter? Because I began to ask, what if our best clinical strategies still miss the person behind the disease? We all know that Huntington's disease is progressive and complex, and our conventional physiotherapy mainly focuses on symptoms. And with the view of illness of narratives, how can we incorporate stories? Because stories help make therapy more meaningful. As Arthur Frank has mentioned, has stipulated in his theoretical approach to this, stories have to repair the damage the illness has done to the ill person's sense of where they are going or in life, because stories are a way of redrawing maps and help us to find new destinations. In its basic definition, what are illness narratives? This is how people interpret and express their experience of illness. In the theory of illness narratives, I will draw upon Frank's typology. There are different types of illness narrative typology, but I will specifically use Arthur Frank's approach in this. He mentioned that and stipulated that when people have an illness, there are three basic typologies of how we look at the illness narrative. There is number one, the restitution narratives. When the person is sick, the restitution narratives tells us the story about the sick person is seeking treatment and looking at the medical professional or a voice of medicine to be healed. And this is the predominant Western narrative that we have. Patients come to us to find treatment, to find answers, to find restitution, as what they say. And this is the predominant narrative of healthcare, of having a restitution narrative. The patient is sick and they seek treatment and they seek help from a medical health professional. The second narrative is what we call a chaos narrative, where there is no meaningful response to illness. Everything we do or with a situation or with the illness, it's not going well. And oftentimes, this is chaos narrative as where we don't find a resolution to a patient's answer or a patient's problem. The third type of narrative is what we call a quest narrative. A quest narrative is finding new insight to the illness. Often, this is predominantly in mainstream media about the quest, as us to fight cancer, to fight for a cure, to beat the illness. And this is what the narrative of meaning of finding a challenge against the illness. And lastly, I propose in my study a type of narrative in the context of progressive neurological conditions such as Huntington's disease, a resignation narrative. That when I listened and viewed and studied people in the course of disease progression, there's the sense of resignation from the person with Huntington's disease and their family, meaning an act of surrender to the inevitable or to the disease progression. We will talk about this different types of typology in the next few slides, and but that is in academic theory of what we call how we look at illness narratives. In a person with HD, there's also a sense of narrative in their identity narratives of who they are as a person. In HD also, they talk about a sense of agency of not withdrawing to the disease, but finding a sense of what they can do, a sense of control in life. And oftentimes, as a disease progressive and the symptoms, there are coping mechanisms that people talk about in their struggles with the condition. And these understanding and looking at different types of narratives can provide us a better context of what we call a patient-centered care. Arthur Kleinman, a prominent neurologist, has deeply ingrained this in medical humanities that he said that narratives can help us transform on the way we understand illness. So in my research, I look at people in with manifest Huntington disease in the course of the disease progression, and oftentimes their narratives challenge the reduction to symptoms. We as healthcare professionals see them with their symptoms, with their problems, and their narratives challenge that way of this is that beyond their symptoms. And patients often express meaning and purpose through the stories that they tell us. And when we allow them to talk about their journey and their stories, it becomes a therapeutic approach because we are always reminded that it is not just the body that we treat, it is also the bearer of a life story. If you want to dwell more about illness narrative and know more about illness narrative, I have provided a further reading in here with look at narratives by Rita Charon on medical humanities, also in different narratives used in physiotherapy practice. And I would like to draw your attention to the work of Soundy and all where he looked at, where the researchers and his team look at different types of illness narratives in three neurological conditions such as spinal cord injury and multiple sclerosis. So there is a further reading if you'd like to explore more about the use of illness narratives in clinical practice. Now, let us revisit our physiotherapy clinical guidelines. Our guidelines is divided into three stages, predominant three stages. When in the early start we promote activity and importance of education. Towards the early and the mid, we look at functional mobility and address the falls prevention. The focus of our therapy is divided as is conceptualized in terms of balance, gait, transfers, and dual testing. And towards the late stages, even though there's not much evidence to what we have collated so far, the work, there is consensus or expert approach of how we as physiotherapists can help in physiotherapy care, posture, and in quality of life towards the end stages. I love this conceptual framework that Monica Booth has started and all and how the very beginning of the physiotherapy guidelines, where we look at different stages of the condition and we classify them in terms of pathology, impairments, and activity limitation. There we put on the main problems usually within the C stages, and consequently the different strategies that we could use in physiotherapy. In first thing, in the pre-manifest stages, we look at a preventative approach with the main goal of delay onset of mobility restriction, and within the early to middle stages, and to maintain function, and towards the late stages, and we look at a supportive type of management and how to limit the impact of the disease progression. And more recently, the work of Una Jones and Camilla Eckhart has divided this into a more comprehensive approach in terms of the fact sheets and how to perform each intervention and the type of training and how to address the limitations that we have and activity and how to use the guidelines in terms of our physiotherapy treatment. These are all available in our EHDN Physiotherapy Working Group website. I'd like also to draw your attention on the work of Una Jones, which as a physical activity of people with Huntington's disease, together with the Huntington's Disease Association England and Wales. This is a good starting point on how we could initiate conversations on how to use physical activity and write the person's thoughts and ideas and how to incorporate them into our therapy and into their routine and into their daily routine. It always boils down to evidence, and we have the clinical recommendations work by Quinn and all in terms of looking at the number of studies we have examined through all the years of people with Huntington disease, and they have recommended this in certain interventions, such as based on evidence, such as the grade A evidence, meaning such with the use of aerobic exercise, and grade B or weak evidence about how this physiotherapy can improve the frequency of falls or balance and other activities that we provide. Within the guideline and the article, I always put into this relatable diagram of how we could use the guidelines in our physiotherapy examination and evaluation. It is very central that we involve the person with Huntington's disease, which we also identify the barriers and facilitators to exercise. And oftentimes it is often very helpful to use their family member or supportive caretaker to understand their whole life situation and their holistic approach to management. And here we can develop the prognosis and diagnosis based on their disease stage, and we can work with individuals as to set goals and to their expected outcomes. From working with the individuals and their family members, we can then determine what intervention or the appropriate guidelines with intervention. And we constantly have this cycle putting the person at the center to guide our work as physiotherapists and to determine the outcome that we would like to achieve in their terms of their physiotherapy approach. But going back to the gap, that what if the patient's symptoms are not the patient's priorities? Oftentimes, as physiotherapists, we see that as falls, but the patient really it doesn't really matter to them if they're falling. What if our guidelines, when we look at the symptoms, that these does not relate to the patient's own priority or the caregiver priority? We look at as healthcare professionals, that we look at the symptoms, but as I've said, like they don't matter to the person with Huntington's disease. And oftentimes, without narratives or without engaging in them, our therapy can feel irrelevant to the patient. And we all know that people with Huntington's disease is progressive and long term in our approach. And if we don't have the same aligned goals, this can lead to disengagement, and often can lead to resistance from patients and their caregivers. And often we always have to make sure that our outcomes, our shared goals, need to align with their therapy and the person's lived experiences. So, how do we bring narrative into physiotherapy approaches? We can begin to ask in our initial conversations what matters to the person, rather than perhaps like focusing on their symptoms. And maybe we could also map narrative profiles within their assessments. And from then, if we begin to better understand what are the priorities of the person, we can map them and we can align them to how we can help them with the disease and symptom management and work toward the rehab goals. Example of this, such as like when they talk about they want to walking the dog, we will use that narrative to help them align by improving their ambulation or physical activity by at least like 20%. And this will lead on to a few clinical tips that I would lead into this discussion. And in the early assessments or when we begin to see patients, we get we can try to use open-ended questions to begin better understand of their own life stories or what are their priorities, and also engaging their family members into open ended questions when they towards the middle and the late stages when communicate when towards the late stages when communication is impaired. Also, we can begin to encourage storytelling in multidisciplinary meetings. Often, like we talk about the patient's stories and not just before the symptoms, especially when the patient and their families are present in those meetings, to let them feel engaged, to let them feel part of the decision making and the stories. And when we evaluate our outcomes with patients, let us reflect back those key phrases and the emotions that guide people that into their practice. And within our documentation, we can begin perhaps to look at narratives alongside our clinical notes and to share this with with a wider MDT, or perhaps like to the patient and the families to have a shared approach in the decision making. One useful tip is the fact sheet that the physiotherapy working group has provided with addressing cognitive, emotional, and behavioral barriers to exercise. And there are very helpful tips of how we can use those strategies to involve patients in their physiotherapy interventions. So in here, in the next part, I will provide a case study of how we have used and how personally I've used narratives in terms of a patient with Huntington's disease. Here we have a patient profile of a 60-year-old female with Huntington's disease of a CAG repeat of 42 repeats, and his total functional scale is 6, which implies into towards the middle stages. The patient has been recently transferred in the care home because care was is quite difficult and no longer supported in the community. Her daughter is distant, and she lives on a different county, and her only support is the nearby younger sister. But relationships are big fragmented because this younger sister is not gene positive. So there's a bit of resentment in there when the person has diagnosed with Huntington disease with their interaction. The main symptoms referred to physiotherapy was falls, identified with moderate lower limb chorea and postural instability. But the BMI also is quite low, which a BMI of 16. And the patient has been recently reviewed by neurologists and the psychiatry team, and currently has like olanzapine, sopicolone to help manage mood and sleep, and dietary supplements to help with sleeps. There are initial barriers because this patient refused any type of care. They refused engagement with any healthcare professionals, and they continue to have low appetite and self-neglect. When transferred to the care home, the patient basically just stayed in her own room for a matter of 2 to 3 weeks and rarely accepts visitors and help from other healthcare professionals. There's ongoing disengagement when multidisciplinary team have visited her, and we continue have like capacity assessments and best interest to the shared goals and how to approach the management of this patient. The other social factors associated with Huntington disease patient is a sense of apathy, of a withdrawal, would often just stay in bed for the whole day, and irritability when patients and family members come to visit or to engagement. There's also a sense of anosognosia, which is like unable to perceive the impact of the condition and the severity of its action, and the aggression is related only to verbal. From a problem behavior assessment scale assessment, there has been no depression and there is no suicidal thoughts or intent. We could see here that this patient's narrative tone is in chaos. The multiple disciplinary team narrative are often disjointed without clear resolution. It's just like asking patient, making sure that the patient is safe and respecting the autonomy and approaches about the result of the mental capacity assessments, although can be fluctuating, but the patient has some insight into the aspects of his care. The best interest meetings often just revolve around how to keep safe and how to keep everyone safe as well, because of the level of occasional aggression to the care staff. Often you will when health professionals came to visit or approach this patient, there is like refusal of leave me alone. I don't want to do anything. As I've said, like the decline of social and medical interventions is predominant in this patient. And all in the next few weeks, the progression of symptoms have increased with the risk of losing of independence and increasing the level of frustration from this patient. The narrative based in a physiotherapy approach of one is divided into at least three stages, three phases, I would call it. In the first phase, it was all about trust building. And when I got to see this patient in the first 3 weeks, it was there was no pressure at all or no set agendas. It's just about the focus on listening and focus of establishing trust to this patient that I am not something that telling her what to do or informing her what to do. It's just like I'm there to listen, just to listen. And this is important because in people with Huntington disease, it takes time to establish trust and rapport. And it is very much important for us to healthcare professionals and to physiotherapy that we have to gain that trust and rapport from our patients. And in phase two, we begin to discover as we let the patient talk and we let the patient like give us like a little bit of her story and also the family story, her narrative identity. We begin to look at her case notes that she was widowed for 3 years. And around that time when her husband passed away, it's the start of the progression of her disease symptoms as well. And there is evidence out there how stress can exacerbate the symptoms of people with Huntington's disease. And within that is also her sense of a housewife. No wonder she doesn't want to do anything because all her life she has been doing it all by herself, taking in her children, taking in and having the responsibility. And when she began to f- feel the loss of not able to complete or do anything, her reaction was just to decline or to resist to all this intervention. And there, in her narratives, we begin to talk about the themes of loss of autonomy. There's an increasing isolation and grief, and the frustration that she can no longer be the person that she wants her be herself. And this is the ongoing exploration we have as an MDT, rather than focusing on her weight, or rather than of exploring her of disengagement or not physical activity. We talk about her family history, her hobbies, and the values that are important to her. What made it into a breakthrough after week 5 or 6 was we discovered that there's one, despite Mary doesn't want to do anything at all or doesn't want to engage on any healthcare professional or any intervention, that there is one thing that she told one of the advisors and her family member to do, that she wants to visit her husband's grave. And that is for me a very important narrative, because from a person who doesn't want to do anything, who doesn't want to get out of the room, there's one thing that she wants to do is to get out and go out in the community and to visit her late husband's grave. This became a narrative pivot where we shift from a quest to the emerging, from the chaos, we don't know where we're going, to a quest that we can use this narrative to help her into something to get out of the room. And how did we use this narrative quest? There, we have used that same narrative that Betty, if you'd like to visit your husband, we should begin to help you get back on your feet. She use the walking aid? She used the walking aid, and due to the safety of the walking aid, I how, we have to replace it with a four-wheeled cloth walker. The work of Anne Clues and has been instrumental because of the importance of the different adaptability of moving aids. And here we identify that it is the best safe form of mobility aids for her to improve ambulation. And within that, with the presence of the moderate chorea that we have, we put weighted weight to stabilize her, answer. Together with that, her physiotherapy intervention focused on little ambulation in terms of her confidence in using the walker into transfer to, training as well, to increase her safety from chair to chair, from different types of chair, and walking. And we even tried to practice on walking from her room out to the car park. These are timed walks with rest, and over time, in the next 2 weeks, we're able to do this to support her endurance. And together, although I just see her once a week, we provided a home exercise program and a carer support to do this to help her with daily ambulation and indoors, with the goal of visiting her husband's grave. And we were able to manage that. It was an emotional milestone for us to get Mary out of her room from a couple of months that doesn't want to do anything, doesn't want to engage, to getting out of the nursing home, and safely supported her with physiotherapy engagement, physiotherapy to help with her ambulation, physiotherapy as well to help with her ambulation training, and to a shared goal of visiting outside the care home and improving her community and social participation. And this didn't just that limit within the cemetery visit. We also provided a little bit of stop off. We asked, Mary, would you like to visit the cafe after you visited your husband? And then we're able to engage her into other nursing home trips, and eventually she's able to be more accepting of that and enhance her social interaction. So we were able to look here at Mary's narrative, which is Quest, which is looking at to able to visit the shared goal of cemetery safely with all support. She didn't talk about her symptoms. She didn't talk about her falls, but she talked about the narrative quest of visiting her husband, and her mood using that all the time has become central, that she able to become more receptive and less resistance because this is something that she wants to do, and more so when she has improved her physical activity and she is able to improve her weight consequently as well. And with her social participation, she was able to engage more with other nursing home residents and able to engage with the care staff in other outdoor queens. The quality of life outcomes is always like a tricky part with Huntington's disease because often when we look at quality of life in studies, it is always meant to be what is meaningful to to the patient, and we have to do this meaningful participation in her Mary's terms. Falls has still been present. There's no major adverse event, but eventually we're able to progress her mobility into a minimum of one person in transfer assist and with and transfers and with standby assist. But in general, her healthcare approaches, and she's been becoming more open to staff and able to help to accept help from medical healthcare professionals. These changing narratives over the course of time for about 3 to 4 years that I have been Mary's physiotherapist have eventually led to what we call the quest to resignation, to acceptance and adaptation. As the disease progressed, Mary began to show signs of not resignation, but not in despair, but in acceptance. There has been decreased aggression, and she'll become more open and calm. The disease have progressed so rapidly that but however, she acknowledged her physical limitations despite the ongoing home exercise program, homegoing therapy and thing. The reality of her condition is her mobility has decreased, has progressed, and the shift of not doing anything was able to have a realistic goal setting and a gentler expectation that in her terms she said, I can only just do what I can. So the physiotherapy has adapted to her what we call her resigned but a cooperative stance, and we focus on towards the middle to the late stages, focusing on comfort, safety and meaningful movement. She accepted the use of the walking aid with a supportive encouragement, and but eventually she has unable to use this more, and she eventually accepted the use of a wheelchair. She maintains cemetery visits and occasional cafe outings, but this is not every time, but only when she is ready. On the day she refused, her choice was respected, and this reinforced her sense of autonomy of what we can do despite everything of her sense of identity. She was taken away from her own home, from her own house, from a housewife, from as a housewife that she does everything for her family, to a care home that everything is being done to them. But at least towards her care stages, she was given that sense of autonomy in terms of her decision making, and more so with her physiotherapy intervention. So, looking at the narrative transitions in here, we could look at Mary's journey moving through different types of narratives. The initial chaos, which is from a resistance and a sense of rotation, from a quest narrative that we found a sense of purpose of what she wanted to do, and we look at it as goal setting. To the end of the disease progression into the late stages is a sense of acceptance and the adaptation to the progression of the illness. Each narrative phase helped shape how our approach to physiotherapy was delivered and received. And each and the same narratives that we continually talk to Mary at the earlier, do you want to visit your husband? Do you want to go? This was reinforced on the same interventions in that we have done with across all aspects of care. And these allow the multidisciplinary team to meet her where she is, emotionally, physically, and her sense of identity, existentially being as a human being. In honoring Mary's story, a life lived with dignity. Mary passed away at a care home, surrounded by her children. But this story remind us that in our role in physiotherapy with people with HD, it's not always physical. It's not always with motor symptoms. It's also the emotional connection that we bring, what we provide and nurture with our patients towards their disease progression, and the relational and the narrative. Because through chaos, quest, and resignations, Mary's voice helped shape her care. What I am trying to achieve here and talk and tell all you that we could use narratives not to replace our evidence in what we do as physiotherapists, but to complement it. Because narrative care supports shared decision making. And oftentimes, when we look at symptoms, it's just one part of a patient's problems. Need to look at holistic assessment and approach, and we have to engage for them in a long-term engagement. So these are important to guide our clinical evidence with the best what we have here in our EHDN physiotherapy working group. That all that we do is also with their lived experience of the individual patients that we see, because this is the basis of the person-centered care. Understanding illness through narrative has a lot of implications for clinical practice. This provides meaning to the patient itself. And also, we navigate a different balance between competence, our ability to listen to patient stories. It is also important to point out that the changing narratives today about looking at providing hope versus a false hope, especially with physiotherapy, and navigating this about how treatment can help them or can eventually like accept their disease progression towards a late stage and set expectations is crucial. This is looking at how people adapt to illness, and we have to guide them into different journey. Because by engaging in active listening to our patients and acknowledging these narratives, this can help facilitate their resilience and well-being. Narratives in reflection don't fix everything, but they help see us the person behind the symptoms. And as Arthur Kleinman once said, people with diseases, their illness has a story, and listening is the first step to healing. My final message and a call to action to all of you and to everyone listening to this talk. Oftentimes, when we treat symptoms, we only address the disease. When we listen to people's stories, we help them transform lives. So next time when we see our patient or a new patient on our an assessment, or a person who is battling a serious illness such as Huntington disease, rather than ask, what are your symptoms or what are your problems? Perhaps we could ask, what is your story? And these are the references that I include in this presentation. And thank you very much for listening.